Now let's continue our discussion with another filarial worm, that is Loa loa. It is commonly called as the African eyeworm, and its vector is that of Chrysops species, particularly C. dimidiata and C. ciliaceae. Chrysops species is commonly called as deer flies, mango flies, also red flies or tabanid flies. Epidemiologically speaking, the parasite is restricted to the rainforests of West and Central Africa. In fact, one of its clinical manifestations, the collar swelling, is a reference to an area in West Africa called Calabar, where the adult worms was first described from a subcutaneous swelling of the eye of a woman. In terms of its periodicity, the microfilariae has a diurnal periodicity, meaning that it increases during daytime, this one here, the microfilariae, and it peaks around or between 12 noon to 2 p.m. Now, speaking of microfilariae, this is the morphological features of the microfilariae. It is sheeted and it's about 250 to 300 micrometers long, and its nuclei extends in the posterior tail tip. And as you can see here, natin yung mga blue areas that represents the nuclei of the parasite. In terms of its adult, the females, which are around 50 to 70 millimeters long by zero point 0.5 millimeters wide, are generally larger than the males, which are around only at about 30 to 35 millimeters long by zero point 0.3 millimeters wide. And these adult parasites live in the subcutaneous tissues, which they can wander around, meaning maglaglaag ni sila. So much so that they can reach the subconjunctival tissue. Yung kag subconjunctival tissue, mao ni sila ang membrane gali nga cover sa white part of the eye. The adult worms are capable of living inside the human host for about 4 to 17 years. Here we have the general picture of the life cycle of Loa loa, and as you can see, because it utilizes two hosts, one an intermediate vector and a definitive human host, mo nang napod sila duha ka stages. We have the human stages in which the adult worms are formed and the fly stages in which the larva will develop. So let's start our discussion with the mode of transmission, and that mode of transmission is when the fly is able to ingest a blood containing the infective stage to humans, which is the L3 filariform larvae. So actually, class, ang life cycle aning Loa loa is much similar to the other filarial worms that we have discussed earlier, kato si Wucherea bancrofti and Brogia malayi. It's just that they differ in two things. Differ sila sa vector o sa habitat sa adult parasite. So once the L3 filariform larvae is already in the bite wound, it will penetrate the skin, and that's the time that it will start the human stages. So at around 6 to 12 months, the larva will mature into adult worms, which will now reside in the subcutaneous tissues. And there it will mate, and the adult female will produce the microfilariae of the parasite. So mao ni siya. And this microfilariae can be found in several parts of the body, which can be demonstrated dito sa spinal fluid, sa urine, sa sputum, sa peripheral blood, and even in the lungs. Now, once the microfilariae are in the blood, it will await for the Chrysops fly to take a blood meal so that it will be incorporated in the blood meal, and it will now start the fly stages. Take note, class, that the microfilariae, as demonstrated in the blood, is also the diagnostic stage of the parasite. And aside from that, it's also the infective stage of the parasite to the victor fly. In there, the microfilariae will shed its sheets, and it will penetrate the fly's midgut, and it will migrate to the thoracic muscles. And there, it will undergo several larval developmental stages. So from being an L1 larvae, it will molt twice to become an L3 filariform larvae. And because the L3 filariform larvae is highly motile, it will now migrate to the head and fly's proboscis, And that's the time that when the fly will take another blood meal to another susceptible host, it will repeats its cycle all over again. This parasite is capable of completing the transformation of an L1 microfilariae into an L3 filariform larvae for about 10 days, and that will serve as the extrinsic incubation period of Loa loa. In terms of its pathogenesis, the disease caused by Loa loa is loiasis, and the most common manifestation out there is calabar swelling. So kaning mga paghubag sa different parts of the body, particularly the subcutaneous swelling on the extremities. Extremities in the form of wrist, sa hands, sa forearms, and lower legs. And kaning swelling, it appears suddenly lang. Kalit-kalit ra ni siya og appear, and it can reach about 3 to 10 centimeters in diameter. Now, it has something to do with the wandering patterns of the adult worms. Ang adult worms gyud ang makakos ani nga naman. So since magwander man ang adult worms and then parasite man na siya, 'di ba? So normally, when there's a parasite or any offending pathogen inside the body, ang buhaton gyud ana sa ato ang immune system is, of course, it will try to eliminate the parasite. So when you say action of the immune system, it involves inflammation. Nya kanang inflammation, including to that kay swelling, kay mohubag. So, say for example, naa sa hands ang parasite, so anha mo swell, anha ang inflammation. But since the adult parasites are capable of wandering around the subcutaneous tissue, posible na siya na move into, say for example, other extremities like lower legs. So, ang parasite wala na diri sa kamot, na siya sa lower legs, ang paghubag mawala na sad. So, wala na hubag diri, and then it will now appear sa lower legs. So that ability of the swelling to disappear in few days only to reappear elsewhere is what we call as fugitive swelling. That's why the other term for calabar swelling class is fugitive swelling. And accompanying that edema or swelling, the host may also experience localized pain. So, especially pain dito sa area kung naaasa ang swelling, pruritus or itchiness, and urticaria or hives. So, na dito yung mga rashes or mga papules nga ma-form nga naay mga red patches which indicates nga naay allergic manifestation. Kay lagi, the main reason for the swelling is not because there's the parasite, the adult parasite in the subcutaneous tissue, but mainly because of the allergic inflammatory response of the immune system of the host. Now, aside from the calabar swelling, other manifestation is in the form of ocular manifestations. So once the adult worms are able to reach the subcutaneous or no, the subconjunctival tissues, that's the time that it causes manifestations in the eyes. So the edema of the eyelids and the conjunctival granuloma, this can lead to proptosis. Ano na may edema of the eyelids? Ang edema of the eyelids class is generally calabar swelling. Calabar swelling siya or paghubag nga naa diha sa eyelids. Remember nga naa diha ang adult worm. So therefore, anha na magka-inflammation. And again, kauban sa inflammation kay swelling. So nihubag diha sa eyelids, around the eyelids. Also contributing to the pathogenesis is the reason that the loose tissues of the eyelids, they are highly prone to fluid accumulation. And di ba kung na-inflammation, managhan man po diha ang blood supply. So meaning kay since daghan mang blood supply, daghan po ang fluids. Mo gyud na nga mahubag gyud ang eyelids. And then nganong naaman po conjunctival granuloma, which is kani. So remember class nga ang granuloma, it's a way of the immune system to deal with a foreign body or a pathogen that it cannot easily destroy. Ang ato ang immune system ang capable of engulfing the pathogen kay mga phagocytic cells like for example neutrophils or macrophages. Now, ang parasite, it is relatively larger than the phagocytic cell. Kaya unsa lamang ng phagocytic cell in terms of an adult parasite. Gamay gyud siya, mas dako kaayo ang parasite. So the body needs to have another mechanism. So what occurs is the body will try to recruit a lot of macrophages, and these macrophages will surround the dead worms in the subconjunctival area, and it will fuse together to form a tight fibrous capsule. So murag iyang isurround ang parasite so that it can slowly eliminate the parasite. Now this capsule will be manifested as a visible fleshy nodule on the surface of the eye, and we call that one as granuloma. So the manifestation now is conjunctival granuloma because that granuloma occurs in the conjunctiva. How about for proptosis, or also called as exophthalmos? Kaning proptosis, it's a result of the severe complication of loiasis, in which the eyes are physically bulging forward out of the eye socket. So the reason for this is when the worms are able to reach the deeper orbital cavity, inflammation will occur there. And this inflammation will lead to the increased pressure sa likod sa ato ang mata. Now, since the bone there will not enlarge, mao nang ang pressure will push out the eyeballs forward. So, man magka-proptosis ang ato ang pasyente nga naay waliasis nga grabe na ka-complicated. Aside from this, other complications may also be nephropathy, encephalopathy, cardiomyopathy. Kay di ba ang atong microfilariae is capable of being established in different organs of the body mo na makita siya sa other body fluids. So, this nephropathy will be affecting the kidneys, and encephalopathy affecting the brain, and cardiomyopathy is affecting, or is a manifestation that occurs in the heart. So, ana ang mga clinical manifestation sa loiasis. Now, how do we diagnose the parasite in terms of laboratory tests? So, of course, we can perform microscopy. That is a detection or demonstration of microfilariae in the blood, and that should be conducted during daytime kaya diba the urinal periodicity man ang lowa-lowa at around 12 noon to 2 p.m. So in terms of microfilariae, we have to take note of its characteristics. The microfilariae is sheeted and it has a presence of nuclei in the tail tip. But class, the downside of detection of the microfilariae in the blood is that the microfilariae in the blood will only appear about after several years. Kaya diba ang adult kay it can exist in the human host for around 4 to 17 years. So dugay-dugay usa makita ang mga microfilariae sa blood. So that means that the host is often negative for microfilaremia. So there's another option for that. That would be the isolation of the adult worm from the eye, kanisiya, or from the biopsy of a subcutaneous swelling or from a calabar swelling. So if ma-demonstrate na to ang adult worm sa lowa-lowa, then therefore we can say that the patient, or we can put into the result that the patient is positive for lowa-lowa and is experiencing loiasis. Aside from microscopy, we can also perform antibody detection with the use of a recombinant antigen. So, unsa man ang recombinant antigen? It is a specific protein that belongs to the parasite that is artificially produced. So, yun sa man pag-produce, it's produced in the laboratory through genetic engineering. So once naa ng antigen, it will stimulate the production of the antibody sa lawas sa tao. Unya, maunay atong gina-detect. Aside from this, we can also perform molecular methods through the use of nested PCR, or polymerase chain reaction. So this type of methods is highly sensitive and highly specific, albeit it needs a lot of expertise. So dapat ang mo-perform ra gid ani kay mga expert na gid sa field, and this is usually very mahal. So therefore it is conducted in confirmatory laboratories. And this PCR detects the DNA of lowa-lowa in the blood. Other results that would support the diagnosis of lowa-lowa includes hypergamma-globulinemia. When we say hypergamma-globulinemia, it means that there's an increase in gamma globulins, mga proteins. Kung sa maning mga gamma globulins, mo na mga immunoglobulins. Kung sa may mga immunoglobulins, mga antibodies. O unsa man ang antibody that primarily increases during parasitic infection. That would be IgE. So that's the primary antibody that increases during parasitic infections, and aside from that, during allergic manifestations or allergic infections. Now, how about for the WBC that primarily increases during parasitic infections? Kinsa man pud na? That would be the eosinophil. So, ma-increase pod or ma-elevate pod ang eosinophil counts. Aside from the fact na ang leukocyte kay mo-elevate pod siya. For the treatment of the parasite, the drug of choice is DEC or diethyl carbamazine, and it's given in multiple courses para mawala gyud ang lowa-lowa. It's effective not just for the killing of microfilariae but also for killing the adult stage of the parasite. Glucocorticoids naman, this is given to the host that is experiencing heavy microfilaremia, that is in order to reduce the allergic or other inflammatory reactions against the microfilariae. For albendazole or ivermectin, this is given to reduce microfilarial loads, although ivermectin is contraindicated in heavily infected patients. Surgical removal, this is rarely done, but if it's done, it's done in order to remove the adult worms that migrate to the bridge of the nose and to the conjunctiva. Moving forward to another filarial worm, we have now Onchocerca volvulus, and it's the causative agent of river blindness. It's also called as the blinding filaria or the convoluted filaria. The reason for this being the causative agent of river blindness is or we can trace the reason for this back in history because historically kaninga parasite, it causes high rates of pagkabuta, especially sa mga tao nga gapuyo dool sa river or in riverside communities, and it has something to do with the victor of the parasite. Kay kaning victor nga Simoleum species, also called as black flies or buffalo gnats, it breeds in fast-flowing water, especially sa mga turbulent rivers or streams. So mao na nga kadtong mga tao nga duol gapuyo sa mga river, di ba kay ang mga tao sa una duol man gyud na sila magpuyo sa river tungod kay naay water supply. So, tungod kay daghan dito ang victor, daghan po dito ang Onchocerca volvulus. Mo na kay since makakos mag-blindness ang parasite, mo nagdaghang mga buta duol sa riverside. Now, it's called as a blinding worm because it's considered as the second major cause of blindness in the world. So, nga nakalala si Onchocerca volvulus. It's also called as convoluted filaria according to panickers. It's because the males and the females, once they are copulating or once magtagbo na sila, they will be tightly coiled, meaning convoluted, inside a subcutaneous nodule. So, adto na sila sa mura og hubag or mura og burot nya inside that burot kay naa didto gakoil ang male o female parasite, especially the fact nga ang female adult worm aning Onchocerca volvulus kay grabe kadagko, so kailangan yun niya pilon-pilon or iyang i-convolute ang iyang kaugalingon para musibo siya dito sa nodule or dito sa capsule. Epidemiologically speaking, it is worldwide in distribution. In fact, it's able to infect 40 million people, but it's endemic in the rural poor of West Africa. It can also be seen, or the parasite is also infecting some parts in Yemen and in some parts of Central and South America. Now, since Simoleum or black flies or buffalo gnats, it does not have any particular feeding habits, therefore, there's no periodicity observed for its microfilariae. So, bisan kanus ara na mo increase ang microfilariae diha sa atuang preferred specimen. In terms of microfilariae, its features include being unsheeted, wala na'y covering sa iyahang lawas sa ato ang L1 microfilariae. It's around 200 to 300 micrometers in size. There's no nuclei at the pointed tail tip of the parasite, and it's mostly found in the skin or dermis. About 90% of the microfilariae is found in the skin dermis, and its 10% is found in the subcutaneous nodules or in the blood, sputum, or urine. Now, since ang kadaghanan sa microfilariae kay makita nato siya sa skin dermis, therefore, the preferred specimen class is the skin, particularly ang skin snips or kanang gikuha na parts sa skin, dili na blood. So in terms of Onchocerca volvulosa, ayaw ninyo kalimti na ang specimen of choice kay skin snips na in order to demonstrate the microfilariae. That is also true for Manzonella streptocerca. So sa Manzonella streptocerca, skin snips pod or skin clippings pod ang atuang specimen of choice. For the adult worms, it has a characteristic transverse striations with annular and oblique thickening around its cuticle. So kaning cuticle mo na siya ang covering sa lawas sa usa ka nematode, which is common to all nematodes. So nadiha ko na yung mga striations or mga linya-linya nga mura og ni pop up or ni thicken. Mo na siya gitawag og annular or spiraling na ni thicken, oblique thickening. And this is one way of differentiating the adult of Onchocerca volvulus from other filarial worms like for example Wuchereria, Broggia, and Loa loa. The female of Onchocerca volvulus is also quite large or is relatively larger than other female worms of other filarial worms. The female is around 35 to 50 centimeters by 400 micrometers and males are around 2 to 4 centimeters by 0.2 centimeters. So, ang iyahang sizing kay naa na sa centimeters, dili na siya millimeters. Iyan nakadako ang adult worm sa parasite and they are found coiled or convoluted within the subcutaneous nodules that they will form. So, inga na lang. As for its life cycle, so nagyapon siya human stages and black fly stages. Kaya iyang victor kay black fly man. And let's start with its mode of transmission. That's when the black fly of the genus Simolium will take a blood meal, transmitting the infective stage to humans na L3 filariform larvae. So once it is in the bite wound, it will penetrate the skin and that's the time that it will start the human stages. Basically, para-pareha ra yun sila og life cycle sa other filarial worms. So makita nato dito sa subcutaneous tissues unya ang kaning mga adult worms kay mo form lagi na sila og capsule nga gitawag nato og subcutaneous nodules. Na dito inside the capsule kay mao na nga magmate na sila, they will produce the unsheathed microfilariae which can be found in the skin mostly. It can also be found in lymphatics of the connective tissue. Occasionally, ang katong mga microfilariae makita na nato sa peripheral blood, sa urine, o sa sputum. Now, class, if na sila sa blood, mag-wait na sila na makaon sa other black fly and that will initiate the black fly stages. So there, ang microfilariae kay mo penetrate padulong dito sa thoracic muscles in which adto na siya mo undergo og larval developmental stages. From being an L1 microfilariae, mo na siya mahitabo nga mo transform siya into an L3 filariform larvae. And that L3 filariform larvae will now be able to be transmitted to another susceptible human host once that black fly will take a blood meal and it will initiate the life cycle all over again. So pare-pareha ra gyud. Managlahi lang gyud sila sa victor o sa asa dapit makita ang mga adult worms. In terms of its clinical manifestations, its pathogenesis, ang disease na i-cause ni O. volvulus is what we called as onchocerciasis. Usually, asymptomatic siya if the load or the worm burden is less, if gamay ra ang worms kani infect sa humans. But if heavy gani ang infections, that's the time nga ma-occur na ang major manifestations, including dermatitis in the skin. So kaning dermatitis, the most common manifestation of this is intense pruritus or intense itching and generalized papular rashes. And this is due to the fact that the host will have an allergic immune response due to the presence of the parasite, especially the dying microfilariae. So ang kaning clinical manifestation sa skin class is attributed to the microfilariae, not so with the adult worms. Microfilariae gyud ang nakakause aning dermatitis. Mahitabuan na if there's a prolonged infection sa skin or sa subcutaneous tissue, ang mahagbong kay mawala ang elasticity kay mawala man ang elastic fibers nga naa sa skin due to the changes that occurs in the skin tungod sa prolonged infection. And it will also cause epidermal atrophy. So katong mga tissues nga nasa skin mag-atrophy to sila, monipis sila, mugamay, and this will now ultimately lead to the loose, redundant wrinkling of the skin. Nya nganong naman po yung leopard skin. So due to the chronicity of the infection because of the repeated death of the microfilariae, the skin eventually loses its pigment. Nya kaning pagkawala or depigmentation kay it does not occur evenly. Dili tanang parts sa skin kay mawala ang iyahang pigment. So large patches of the skin becomes pale due to the fact na wala na ang pigment, pero there's also spots in which the normal pigmented skin is scattered all throughout. Now, this will give an impression kaning naay area nga walay pigment unya area nga naay normal pigment. This will give an impression of a spotted pattern. Nya, kanang spattered pattern is now what we called as the leopard skin. Mura daw kung na siya skin of leopard nga na ay wala kayo pigment o napoy grabe ka pigmented na area. Mura siya na ay lingin-lingin. So, the class, if naay depigmentation na mo-occur diha sa imuhang leopard skin, ang sa soda baliktad, the opposite occurs. Ang SODA, it's a result of hyperimmune response, particularly to the formation of autoantibodies. May kag autoantibodies, ang antibody na na-form sa lawas, ang iyang target kay dili na ang katong foreign body. Ang target niya is ang component sa ato ang lawas itself. Particularly, kaning sa soda, ang mga defensins. And this will now cause the skin to become intensely dark. So, again, sa leopard skin na ay depigmentation, meaning na nga wala ang pigments. Pero, there is a soda, kani siya, kaning chronic hyperreactive form of dermatitis, ang nahitabo, ang skin will become intensely dark, meaning na ay hyperpigmentation. Aside sa na ay hyperpigmentation class, ang skin po, it will become massively thickened, mahimo siyang scaly, which indicates nga dry kaayo ang skin, and it will become severely itchy. Grabe kakatol. And this only occurs in specific area of the body. For example, isa ka tiil, one leg. And this is accompanied by a dramatically swollen lymph node. Mo na characteristic sa soda. May kag leopard skin, may kag depigmented, pero pag soda, hyperpigmentation pod ang nahitabo. Aside from skin or dermatitis, na putay gitawag nato og oncocercoma. Ang oncocercoma mo na ni ang subcutaneous nodules. 'Di ba ang subcutaneous nodules kay mo ni ang ga-contain sa adult worm. Now, this nodule or ang usa ka burot nga nasa lawas sa tao, it appears as though firm siya, non-tender, and it's variable in size. So, it exists for about few millimeters to about 10 centimeters. And it's common over the trunk, particularly in sacrum and in hip area. It can also occur in other superficial areas, like for example in scalp, in the scapulae and the ribs, in the iliac crease, and in the knees. Now, the reason for this nga nung magka-nodule class is not because the parasite is capable of producing the nodule. It's actually because of the host immune response. 'Di ba? We have to go back to unsaon pagpatay sa ato ang immune system if dagko kaayo ang mga pathogen. Ang ilang i-forman good class is katulaging capsule. So aside from the macrophages, it will now recruit mga fibroblasts, and 'di ba ang fibroblasts, they are capable of producing collagen and other parts of the connective tissue, and by the time nga naan na sila, it will physically cover the worm. So kanina time makavira na ang worm. Now, ang problema ani, ironically speaking, ang kaniunta nga nodule is advantageous to the human body or to the host nga naman because it will isolate the parasite. Kaya dili siya makakause of any manifestation. However, this nodule or this oncocercoma is in fact beneficial di ay siya sa parasite because the parasite there, the adult worms that are tightly coiled, they are viable, meaning buhi sila. And since they are viable, they are capable of mating. So nakahide hinoon sila against the immune response. And there, once they mate, the female will produce the microfilariae. And this nodule, this oncocercoma, is porous enough, yung kay porous enough, ang ihang buho kay enough para sa mga microfilariae sa ovolvulus to go out of that nodule. And it will now penetrate and it will now go to the subcutaneous area. Mauna siya nga magsigig og kanaghan gihapon ang parasite although nga gitapukan na siya sa mga macrophages kay lagi di ay viable pa siya inside that nodule. And that clinical manifestation is what we called as oncocercoma. And in fact, class, ang adult worms nga naa dito inside sa oncocercoma, it is capable of living for about 10 to 15 years. Ingay na kagrabe. So, in that 10 to 15 years, abi sa lawas sa tao nga na-eliminate na ang parasite kay gitabo na nagod na nagoy nodule. But in fact, buhi na dito niya sig panaghan ang parasite. Now, aside from oncocercoma, naabot ay gitawag nato og ocular involvement. So, in ocular involvement class, the main reason naman for this is the death of microfilariae. Nya kaningang death sa microfilariae, this will trigger violent immune response. Nga naman, so say for example, the most common early finding is conjunctivitis with photophobia. So sa conjunctivitis, once the microfilariae reaches the conjunctiva and it will die there subsequently, kaya wala naman dito ang iyahang kuan kanang mga pagkaon na hurot na, mamatay siya dito. Of course, the body or the immune system will try to eliminate ang katong microfilariae, and this can lead to inflammation. When there's the inflammation in the conjunctiva, the blood vessel supplying the eye will dilate. Moborot siya dito, and of course, since na ay dilation, naputay swelling sa mga tissue. And this now, the inflammation in the conjunctiva is what we call as conjunctivitis. So, nitabuan na eyes are chronically red, they are watery, and the eyes are also inflamed. Now, if the conjunctiva is inflamed, this actually irritates the sensitive nerves of the eyes. Itong mga nerves nga nasa eyes. And this can lead to the nerves being highly reactive and painfully sensitive sa light. And that is the condition that we call as photophobia. And again, this is the first sign that the parasite has already invaded the eyes. Now, after that, as the disease progresses, natay acute manifestation, which we call as punctate keratitis. So sa punctate keratitis naman, the microfilariae migrates towards the deeper layer of the eyes, specifically dito sa cornea. Now, when the parasites die there, of course, the immune system will try to destroy it and eliminate the parasite. And this can lead to a localized attack. And if na localized attack, napoy inflammation na mahitabo. This inflammation now will lead to the production of tiny, fluffy white spot na ay mga white areas dito sa cornea. And this white area, since scattered around man ang worms, scattered around pod ang mga white areas. And this white tiny dots, once they manifest in the cornea, they're called as snowflake opacities. So mona ang punctate keratitis, it is associated with snowflake opacities as what ophthalmologists call the condition. How about for sclerosing keratitis? Ang kaning sclerosing keratitis, this is a result of years of chronic inflammation, especially if onchocerca volvulus infection is untreated. It causes the formation of a scar tissue and new blood vessels from the edges of the eye padulong na sa central area sa mata. So, ang katong clear parts sa mata, this will now be replaced by scars. So, magka-scarring dito, and then ma-form na ning whitish na area here. Ma-white na, and will now creep sa ato ang pupil, ang pagka-white na area, as if it blocks the light from sa ato ang mata. So kani di ay na white area, these are now scars di ay associated with the presence of um, the microfilariae in many, many years of the infection. So it's a part of a chronic, it's a result of the chronic inflammation associated with the presence and the death of microfilariae. And eventually, the end stage of this, which is the most serious complication, is bilateral blindness. Kaya di ba, dili naman na kausa mo supply og microfilariae didto sa mata. Kadaghan man na kay kadaghan man pod mo produce og microfilariae ang mga adult worms nga naa sa oncocercoma. So, within the 10 to 15 years, magsigi og hatag or magsigi og ngadto ang microfilariae dito sa mata, mao na nga magsigi pog kaguba. And again, dili lang ang isa ka mata ang maapektuhan ani, both the eyes. Mo nang mo result siya into bilateral blindness or river blindness. And this is attributed by multiple failures. One, in front of the eyes, na diha ang sclerosing keratitis, in which mablock ang light, di nakakita. And at the back of the eye, ang mga nerves kay na damage na pod, which kills the cable that sends images to the brain. So overall, mabutag yun ang pasyente. Other manifestation includes anterior uveitis and iridocyclitis, which is the inflammation of the iris and ciliary body or the middle layer of the eye. Retinal pigmentation, which is characterized by the deposition of abnormal pigmentation of the retina. And secondary glaucoma, which is caused by the increase in ocular pressure that leads to the damage of the optic nerve of the eye. So, muna sila yung other clinical manifestations, although ang kaning conjunctivitis, punctate keratitis, sclerosing keratitis, and bilateral blindness, mao gini sila ang associated with the presence of onchocerca volvulus in the eyes. When the onchocerca volvulus will manifest in the lymph nodes, it can cause lymphadenopathy in the inguinal and femoral areas, and this enlarged nodes may hang down, causing the hanging groin appearance, which can predispose hernia. Ang kaning hernia mo na siya gitawag nato og danlac, can predispose danlac, especially if ang kaning lymph node enlargement can occur sa inguinal area. Now, how do we diagnose the presence of onchocerca volvulus? It is demonstrated through the gold standard method, which is our skin snip smear. And that detects for the presence of microfilariae because diba, 90% of the microfilariae is found in the skin, especially in areas with maximal microfilarial density. Like for example, in iliac crease and in the trapezius region, kanang at the back portion sa lawa sa tao. So what happens here is that the skin is lifted with a needle and a small piece of the skin about 1 to 3 millimeters is excised. And this specimen or sample is placed on a slide in water or saline. So it is incubated in order for the microfilariae to emerge from the skin. Around 60% of it will emerge in about 30 minutes and 75% around 24 hours. In order to differentiate the microfilariae from the other microfilariae of filarial worms, that is done through staining with GEMSA and hematoxylin and leucine. And the specimen is best collected around midday para makita gyud nato ang mga microfilariae. Aside from that, other methods of demonstrating microfilariae is through the collection of aspirated material from subcutaneous nodules and in conjunctival biopsies for those with ocular manifestations. We also have here Mazzotti skin test, in which there is a topical application of diethyl carbamazine on the skin that leads to the local reaction, maybe erythema, or it can also be itching. And this is a reaction towards the dead worm. This can be done only in light infection without eye involvement because the reaction may become severe, especially in heavy infection. Aside from this, we can also perform subcutaneous nodule biopsy for the detection of adult worm, but this is less sensitive as compared to other methods. In serology, this is useful in cases in which microfilariae are not demonstrated in the skin. And in fact, ELISA, or enzyme linked immunosorbent assay, is said to be more sensitive than skin snips, according to Panickers. We can perform antibody detection for this one utilizing recombinant antigens. For molecular methods naman, it is done so with the use of PCR, that is to detect the oncocircle DNA in skin snips. By the way, in serology, what is the downside for this is that it cannot differentiate current from past infection. Kaya lagi, ang antibody, it can persist not just during the time of infection, but even during or after nga mo subside ang infection. It can persist for over a lifetime, especially kanang mga IgG. Other methods that can be used in order to support the diagnosis includes eosinophilia and elevated IgE. For the treatment and prevention, the drug of choice for onchocerciasis is ivermectin. It is active against microfilariae, but it's not active against the adult worm. It is contraindicated also in areas that are co-endemic for Onchocerca volvulus and Loa Loa. Surgery, it is recommended when nodules are located on the head. And vector control, this is useful in highly endemic areas. The last of the filarial worms include the Manzonella species, including Manzonella ozarde and Manzonella perstans, in which the adult worms resides in the serous cavities, and Manzonella streptocerca, in which the adult worms reside in the subcutaneous tissues. So for Manzonella ozarde class, the vector for this one is Colicoides species, or the midges, and Simolium amazonicum, which is a species of black flies. Its clinical features is mostly asymptomatic, but if the worm burden is high, it can lead to lymphadenopathy, urticaria or hives, pruritus, pulmonary symptoms, arthralgia or pain in the joints, and keratitis. For its diagnosis, the microfilariae is demonstrated in the blood. So blood atong specimen ani, and this microfilariae is non-periodic, it's unsheeted or non-sheeted, and it has a pointed tail without any nuclei. The adult worms, they can be found in the peritoneal and pleural cavities of humans. As for its treatment, it is ivermectin that is indicated. For Manzonella perstans naman, this is also known as Acanthocheilonema, Dipetolonema, or Tetrapetalonema perstans, according to Panickers. And the vector for this one is Colicoides or midges. Its clinical features include angioedema, meaning there's a deep tissue swelling due to the fact that it is commonly residing, or the adult worms are commonly residing sa serous cavities. Aside from angioedema, we also have, or it can also cause urticaria and pruritus. For the diagnosis, microfilariae is demonstrated in blood or in serosal effusions. It is non-periodic, it is unsheeted, and it has a blunt tail tip with nuclei. So, ang tail tip kay kani nga naay nuclei. The adult worm lives in the body cavities of humans, mainly in the peritoneum, less in pleura, and in pericardium. As for the treatment, diethylcarbamazine or DAC and albendazole are indicated, but according to Panickers, the first effective treatment is doxycycline. For Manzonella streptocerca naman, it is still also called as Acanthocheilonema, Dipetalonema, and Tetrapetalonema streptocerca. Its vector is still Colicoides species, which is a species of midges, and its clinical features includes inguinal lymphadenopathy and chronic dermatitis with hypopigmented macules and itching or pruritus. The microfilariae, because they are usually in subcutaneous tissue, it is demonstrated not in the blood but in skin snips or skin clippings. Remember that one, ha? Onchocerca volvulus and Manzonella streptocerca, Its specimen of choice is skin snip or skin clipping. The microfilariae for this parasite is non-periodic, unsheatheded, blunt, with a curved tail tip with nuclei. So that's why its tip is so curved that it can also be called as the shepherd's crook, or it resembles the shepherd's crook. Its adult worm resides in the subcutaneous tissue, particularly in the dermis or in areas just under the skin. For its treatment, the indicated treatment is diethyl carbamazine. Now, for the life cycle, it's also the same as other filarial worms, so I will not be expounding more of this. But again, they differ in just in their victor as well as the area to which the adult worm resides. But for the rest of the part of the life stages, they are basically the same. This also for Manzanella persistens and also for Manzanella streptocerca. Now we have the non-filarial worms in the form of Dracunculus medinensis. This parasite is known since the antiquity. It's also called as the guinea, the serpent, the Medina worm, and the dragon worm or the fiery serpent, which is indicated in the Bible that have tormented the Israelites. It is also believed to be the serpent worm on the stick that may have given rise to the physician's symbol of caduceus. Kana ganing murag kuan nila kanang symbol sa mga physician or sa mga doctors. Mao daw ko na Dracunculus medinensis daw na siya. It is also considered as the longest nematode infecting man, and it has two hosts in its life cycle. Man serves as the definitive or the final host of the parasite, and copepods in the genus of Cyclops serves as the intermediate host. As with the morphology of its larva, its larva measures around 500 to 750 micrometers in length and 15 to 25 micrometers in breadth. It has a broad anterior end and a slender filariform tail. Its cuticle of its larva has a prominent striations, and it has a motion described as coiling and uncoiling. So, yung movement sa larva ba? Okay, it's described as coiling and uncoiling. For its adult worm, it has a smooth, milky white cuticle. Kani, this is the adult female of the parasite, resembling a long piece of twine. And this adult female can be present for about a year dito sa body of the host. The male is rarely seen, and it resides usually in the subcutaneous tissue of the legs, arms, and the back of the body of the host. Now this is the life cycle of the parasite, and the life cycle will start with a mode of transmission in when humans drink unfiltered water containing copepods with L3 filariform larvae. Kaning copepods, these are freshwater crustaceans that is infected by the L3 filariform larvae. And once the L3 will be manifested in the body of the host, inside the intestinal area, the larvae will be released when the copepods die due to the killing with gastric acidity of the stomach. And now the larvae will penetrate the host stomach and into the intestinal wall. Will they mature for about 10 to 14 months or about 1 year. And once they mature, they will now reproduce. So the female worms will migrate to the surface of the skin, especially sa mga areas kung asa ma-expose sa water or it will come in contact with water. The common site is the leg, but it can also occur in other sites, although rare, like for example, sa arms, the shoulders, the breasts, the buttocks, or even in the genital area. And once na dito ang gravid na female, it will create a blister. So, kaning blister, this is due to the fact na mo-release og toxin ang female niya, mo-form na ang blister. And this blister will eventually burst out, and that's the time that the female will discharge its L1 larvae. So the L1 larvae will be released in the water from the emerging female worm, and this usually occurs about 1 year after the infection. So once ma-release na sa water, the L1 larvae will be consumed by the copepod, and that's the time that it will undergo developmental stages into becoming an L3 filariform larvae. That's why the L3 larvae is considered as the infective stage of the parasite, whereas the female worm that is emerging from the skin after 1 year of the infection is considered as the diagnostic stage of the parasite, which can also be which we can also demonstrate the L1 larvae together with the female worm. So pasabot na posible pod si L1 larvae to become a diagnostic stage, but it's really the female Dracunculus medinensis that's the diagnostic stage of the parasite. Now, in terms of its pathogenesis, Dracunculus medinensis causes dracunculiasis or dracunculosis, and it is manifested through blister formation. This blister formation starts from a painful papule that enlarges to become a blister, and it's accompanied by local erythema, urticaria, fever, nausea, and pruritus. This commonly involves the lower leg, the ankle, and the foot of the hose. And in that blister, once mabuak na siya, gravid adult female emerges near the surface of the skin. That yellowish fluid that is accompanying the blister is actually sterile class, meaning it's only composed of polymorphs or polymorphonuclear cells, eosinophils, and mononuclear cells. Now, if sauon siya bacterial complication, kay it may lead to sepsis, local abscesses, and pyogenic arthritis. Especially if dili na siya maayo og hunad, if dili siya matambalan. For the laboratory diagnosis, the detection of adult worms is done when gravid female appears in the surface of the skin when the blisters are naguba or nabuak. For the detection of L1 larvae naman, we can place the leg ulcer in a cold water so that the L1 larvae will be discharged and makita na nato siya, ma-demonstrate na nato siya sa tuang specimen. Other tests includes antibody detection via ELISA and immunofluorescent assays, IFA, and peripheral blood eosinophilia. We can also perform skin tests for this matter. We can perform intradermal skin tests with guinea worm antigen para maka-create siya og positive reaction or indulation. As for the treatment, we can perform worm removal, that is the extraction of the worm over a period of 15 to 20 days using a stick, usually by twisting it. And yung kanida ko na method is said to be devised by Moses. We need worm removal because there's no anti-helminthic drugs known to be effective in combating the Dracunculus medinensis infection. As for symptomatic treatment demand, we can perform wet compresses to affected skin, and we can add analgesics to that in order to relieve pain and also administer topical antibiotics. Finally, we have the causative agent of zoonotic filaria, the species of Dirofilaria. Since this parasite is a parasite of lower animals, it will undergo incomplete development. So immature adult worms rani ang ma-form dito sa man, particularly sa lungs, eyes, and sa subcutaneous tissues. Its transmission is attributed to the bite of infected mosquito. And this infected mosquito carries the infective stage to man, the L3 filariform larvae. Now, when this L3 filariform larvae will develop into immature adult worms, it can now cause clinical manifestations, particularly the formation of subcutaneous nodules, which is caused by several species, like for example, D. repens from dogs, D. tenuis from raccoons, and D. orsi or orsi from bears. For pulmonary manifestation naman, this is attributed by D. immitis, which is also considered as a dog heartworm, but in man, it can cause pulmonary complications. For ocular manifestations, particularly in sclera and conjunctiva, it is caused by D. conjunctivae. For its diagnosis, the identification of adult worms is important through surgery and autopsy because microfilariae they are not found in the blood or tissue. For the treatment naman, that is also surgical removal of adult worms because no chemotherapeutic agent is effective for Dariofilaria species. And that is the end of our discussion. Thank you very much, everyone, for listening. I hope that you really study well for your P2 examination. God bless everyone.